think we're ready to get started. I'm Walt Buteau from Channel 12. I know in our field we cover these deaths and these tragedies a lot. They're in the beginning of stories, they're in the arraignments of people, they're mentioned in closing arguments, and of course they're a big part of crime and a big part of some of the stories we try to do as far as awareness. And to give you an idea of how important of a subject it is, as you all know it's important, the room's full. I believe they had to turn a few people away as well. So we're going to get started as quickly as possible. But we want to begin, if everybody can stand up. And just consider that the audience obviously made up with of a lot of people who have lost loved ones. So we want to start with a moment of silence. We're going to begin now with a series of speakers, and I think the term front line is overused a lot in our world. We talk about it, and it doesn't mean as much as it does for the mother of two children who she lost to this problem. So we introduce first Elise Reynolds.
Thank you.
Good evening, everyone. I'm here as a mom first and foremost. A mom due to overdose that has lost two of my three sons. I think we were an average family. Their father and I worked very hard to do the best we could. Their father was a long-haul truck driver. He was gone an average of 2 weeks at a time. I worked as a waitress and did clerical work to raise my boys. When my youngest Paul was 16, I returned back to school and obtained my LPN. We were active with our boys. We tried to keep them as active as we could. We took them camping. We had camping vacations. They were great kids. We raised our boys with a lot of respect and to treat people the way they wanted to be treated. And it's been said, even by the Seacon Police Department, that the Cooney boys, no matter what they did, they were always so very respectful. Anybody that was lucky enough to know them would always tell you what great kids they were. And yes, I do have three boys. My oldest son, his name is David. Unfortunately, he has given me a daughter-in-law and four beautiful boys. Sometimes that's where I think I make my mistake, because I've seen David with his boys, and he's kept them busy and occupied in all the sports, and I wasn't able to do that with them because it was just me most of the time. But they were still great kids. Oh, we weren't given lessons on how to be moms or dads. We raised our children in what we thought was a healthy environment. In April of 1989, I had back surgery. And when I was discharged from the hospital, I was given a prescription of oxycodone. 89, I didn't know what oxycodone was. I didn't know what opiates were, what benzos were. You know, there's no education. They're writing out these scripts, they're not educating people. They're not telling you the dangers of what that medication is. I took one of those pills, didn't like the way it made me feel, and I put the bottle back up in the medicine chest. I never thought about it. You know, to this day, I don't know when that bottle disappeared. I know it wasn't my boys because they were very young, and it wasn't something that maybe I didn't think that they would think of. So, I mean, that's just an example how drugs are getting out on the streets. We don't know what we're putting in our medicine chest. Oh, I'm sorry. I started working in a methadone clinic in 1998 after I obtained my LPN. David was 23, Ted was 18, and Paul was 17. I never thought of talking to my sons about drugs. No, it wouldn't happen in my home. This is what I do for a living. They would know. Well, guess what? I was wrong. By the time Ted was 20 or 21, he had 2 trucks contracted with a local furniture company, and he was making great money. He had a beautiful Camaro. He was just enjoying life. Well, one of his so-called friends, who happens to be the older brother of a boyhood friend, introduced him to oxys, 80 milligram oxys. Next thing you know, that's it. He must have been addicted. My son Paul, I don't know how he got addicted. I know at one time he did have a very bad motorcycle accident, and they were having a very difficult time medicating him, relieving the pain when they were trying to take all the road out of his back, out of his butt, out of his arms. He spent a couple of weeks in the hospital with that. He came home, we had to change his dressings. His dad would do him in the morning, I would do him in the evening. He got through that, but I don't know if that's where his addiction started. Back to where I was, I'm sorry, I lost track. So, and there was another time that I went and visited Paul at Memorial Hospital. He had OD'd on a fentanyl patch. He had sucked the gel out of a fentanyl patch. And of course, I learned about that later on. I was not aware that when my son got arrested of what his charges were. Leonard Diddy from the Journal did find out that he was arrested for dealing. He spent 3 months in the prison system in Massachusetts. So you know he had a cold turkey of detoxing. They don't do anything out there. Teddy was just fighting the battle. But during the time that Paul was in prison, Teddy was able to go clean up. He got 3 months clean. Paul came out of prison, he was clean. They were doing great. My boys were doing wonderful. And that was probably the end of May of 2004. Well, June 11, 2004, on a Friday morning, 4:30 in the morning, I got the horrible phone call from their dad. Paul. We lost him. I never had the opportunity to help him. He never reached out to me. That kid, there was so many people at his funeral, it was just unbelievable, the outpouring of love and support. Well, I don't have to tell you, unfortunately, Teddy relapsed. We had Teddy for an additional 6 years. It was an up and down battle. Treatment here, treatment there. Sometimes I don't think he did it for himself, sometimes I think he did it for me. He had about 2 months clean time. I taught him how to get on Facebook. He connected with his cousins down in Florida that he hadn't seen in many years. They knew about his addiction, he had talked to them. They sent him an airline ticket. He went and spent the best 2 weeks of his life with them. And he was intending on going back. But he had to come home to clean up some legal issues. Well, he got home on a Thursday afternoon. I seen him that Thursday night, showed me all the pictures, they had a great time, he looked wonderful. Well, again, another Friday morning at 4:30 in the morning, I received that dreaded phone call again. And unfortunately, it was their father, again, who found Paul. Teddy. It's just a heart addiction. We gotta do something to change things. We gotta stop getting these pills out to these people. I don't know what else to say. I live with this every day. I miss my children so much. But the last thing that I have to say, you need to be very careful what you pray for. Thank you for listening.
Thank you, Elise. Next, the head of the Rhode Island Department of Health, Dr. Mike Fine.
Good evening. The story is heartbreaking and the numbers are startling. Probably too much to bear. We've had 45 deaths in Rhode Island since January 1st, 33 on weekends. 7 reported since Friday's press briefing. Of 41 screened so far, 28 involve fentanyl. They're from 15 different cities and towns, 33 men, 12 women, 40 white, 5 black, ages 20 to 62. For every number, there's a story like Elise's. Drug addiction touches everyone in Rhode Island and everyone in the United States now. Too many have lost loved ones. These are our colleagues and friends, our brothers and sisters, our mothers and fathers, our daughters, or, as in Elise's case, our sons. Here's what we need to do together. We need to make Narcan available to everyone who uses. We need to make Narcan available to families and friends. We need to make Narcan available to all police and all first responders throughout the state. And we need to help everyone who's using get into treatment, stay in treatment, and stay in recovery. That means surrounding all Rhode Islanders with what Tenny Gross calls the beloved community. We can't let anybody go through this alone. It's hard. It's hard to kick it, it's hard to shake it, and it's too hard to do by yourself. This is all of us together. There are some people who say, and I've been seeing some really tough stuff that I don't like on Facebook, which I try to stay away from, that there are people who are addicted, that people who are addicted aren't worth saving. A human being not worth saving, a Rhode Islander not worth saving. The tradition that built this hospital believes that when you save one life, you save the world. So let's do what we can to care for all the fellow Rhode Islanders. Let's do it together, and let's do it today. Thank you.
Thank you, Dr. Fine. And next on our panel of speakers is Rebecca Bosch. She's the Administrator of Behavioral Health Care Services for the Rhode Island Department of Behavioral Health Care, Developmental Disabilities, and Housing.
Thank you, and I'm very excited to be here and very glad to have this opportunity to talk to everyone about this overdose epidemic and what it is that our department views as necessary responses to this epidemic. And I basically see that there are three components to addressing this. One is prevention. So we need to work with the Department of Health, we need to work with our community to stop people from misusing substances to begin with. And that's number one. Number two, as Dr. Fine mentioned, we need to work on intervention. We need to be able to respond to somebody in overdose. And in doing that, our department 2 weeks ago issued emergency regulations that require all of the agencies licensed by the Department of DHS behavioral health care organizations to be trained in the administration of naloxone, to train their clients who have histories of opioid abuse and dependence in overdose and the administration of naloxone, to offer all patients with histories of opioid abuse and dependence access to naloxone as they leave treatment, and especially for individuals leaving residential and detoxification facilities, access to naloxone before they step out the door, because we know that is when people are most susceptible to overdose, most vulnerable, because their tolerance levels have decreased, and they're going to be going back out into the community where they're going to have access. And we know that that's when people are prone and vulnerable to overdose. And finally, part of the regulation was to require our opioid treatment programs to become certified as health homes. Health homes are an opportunity for our treatment providers to work with the medical community to manage folks with histories of opioid dependence, not only their substance abuse, but the chronic conditions that they often present in treatment with. So we're really expanding the treatment that individuals get and the depth of that treatment that they get from our system in issuing these regulations. But finally, it's treatment that I want to talk about as the third component, and that's really the primary one. The message here is that treatment works, recovery is possible, and overdose is preventable. And I know that I recently have been reading the articles that you've been reading and saw one that quoted an emergency department physician saying, well, there's really very little we can do for these folks that come in an overdose. I can't get access to treatment. And unfortunately, I think that's the perception that exists out there, is that treatment is just inaccessible. It may be if what you're equating to treatment is the immediate access to a bed. And unfortunately, that is how society has viewed treatment, as a bed. But really, effective treatment for opioid dependence is outpatient. And you don't need to have immediate access to a bed. You need to have connections to outpatient treatment. It was ironic that when we had originally scheduled this a couple weeks ago when we had a snowstorm, I had just received some information in the mail, the email, quoting 2 articles looking at evidence-based practices. And the first sentence is, detoxification followed by abstinence has shown little success in reducing illicit opiate use. Really what we're talking about is expansion and access to medication-assisted treatment, which is shown to be effective in the reduction of illicit opiate use. And so we're talking about methadone, and we're talking about Suboxone, and we're talking about Vivitrol, because there are tools now for recovery for individuals who have opioid dependence that weren't necessarily available or accessible a long time ago. And we need to start to help the community, help the medical community, and help the recovery community to realize that medication-assisted treatment is recovery. And individuals who are receiving medication and remaining abstinent from illicit substances are in recovery. And that stigma and that perception that exists in those communities, including the recovery community, the medical community, has kept people from accessing the tools that they need that could save their lives. And I'll relate to you another story. I sat in a meeting with some nurse care managers who work in certain health facilities, and one of them said to me, well, how do I get somebody to access treatment? We have this kid, and he keeps overdosing, and he ends up in the emergency department, and what do I do with him? And I said to them, there is an opioid treatment facility, there's a methadone maintenance treatment facility in your area. This person has coverage. What about trying to get them into that particular facility? And the response that I got, I'll never forget, well, the doctor doesn't like methadone. The doctor doesn't like methadone. And he's waiting for a Suboxone slot to open up. And my thought was, in the meantime, I hope he doesn't die. And it's almost like having a cardiac surgeon say, well, I don't believe in angioplasty. You might need it, but I don't believe in it, so I'm not going to refer you for that. I don't know how we can break through the stigma that exists in the community about methadone, but this is a life-saving drug. It really is. And it helps people access recovery that they may not be able to access. It's not the only drug. Suboxone is available too. And so we need to look at the access to Suboxone, and I know that's an issue, and that's one of the things that people talk about. And we've talked about the expansion of Suboxone in the community. The 100-patient cap that exists for Suboxone is not a state one, it's a federal one. And so if we want to look at changing access to Suboxone and changing the caps that exist, we need to work with the federal government, not just the state government, to look at that. And I would advocate for that because Suboxone is effective, but however, it's not regulated at this time. And so in advocating for that, I would say to you, we need to look at making sure that the Suboxone treatment that's out there is quality Suboxone treatment and people are getting quality care. And look at other states like Vermont that has created regulations around the use of Suboxone so that it is regulated and you don't see the kind of programs that were identified in the New York Times article about Suboxone. And finally, to combat stigma, I think that we need to work with the medical community. And one of the exciting parts about having health homes in our opioid treatment programs is the fact that that's exactly one of the things that we're trying to do, is make sure that the medical community is not afraid of individuals with opioid dependence, that the medical community is willing to treat people who are receiving medication-assisted treatment and refer people to medication-assisted treatment. So what can we do? Well, we need to work on that stigma. We need to work on that stigma in the recovery community. We need to work on that stigma in the medical community. We need to work on that stigma around the entire state of Rhode Island. And one of the things that I think that we can talk about doing here is requiring that all insurers cover medication-assisted treatment and Narcan. Up until now, we've had a very generous state benefit through Medicaid that has covered medication-assisted treatment always, but not all insurers do. And the limited access to medication-assisted treatment is something that we need to talk about. Now, with the advent of the Affordable Care Act, many people who could no longer afford treatment are able to get treatment, and the access is less of an issue for those people who don't have a lot of money, but for those that have commercial insurance, medication-assisted treatment can be quite expensive. And finally, I think we need to look at finding a way to regulate Suboxone and at the same time expand capacity. What Massachusetts did was interesting in that they placed nurse care managers in some of the federal health centers so that there was assistance for physicians and they got more physicians to become waived to provide Suboxone treatment. So basically the message is this: treatment is effective, the right treatment is effective, and recovery is possible, and overdose is preventable.
So the final speaker from this portion of the night will be Michelle McKenzie, who's the director of the Pony program with the Miriam Hospital.
Thank you all. It is very exciting to be here tonight, and it's exciting because the energy in this room is tremendous. This is exactly what we need to address the real crisis of overdose deaths that are happening in our state. And what I'd like to do tonight is tell you what you can do to address overdose deaths. The first thing to do, the first step to take is, as Becky suggested, is to get treatment. If there's people who are struggling with addiction, or loved ones people who have loved ones who are struggling with addiction, the treatment access is much better now with the Affordable Care Act. If you don't have insurance, go on Health Source Rhode Island and get insurance. As Becky suggested, Medicaid covers methadone and covers Suboxone. And I want to suggest specifically is that if you're not sure and you're trying to figure out where to go, call Anchor. Go online, find out what the number is. They are there 6 days a week, and they will help you get to the right place. And I also want to offer some help for loved ones. This is not, the addiction is not a problem that impacts an individual. It impacts the family. It impacts the whole community. And we have been hoping to do something similar to what they have in Massachusetts called Learn to Cope. And this is a gathering of parents and family who have children or loved ones who are struggling with addiction. And I want to find Rebecca. Rebecca, could you stand up? Rebecca McGoldrick is with Protect Families First. She's going to make a brief announcement when it gets to the community portion. She will be taking names, and we really hope that people will take advantage of it. If you have a loved one who's struggling with addiction, opioid addiction, please touch base with Rebecca, because we want, this group will be both for advocacy, support, and resources. We also, LunarCorp is really focusing for parents and loved ones who have children in active addiction or loved ones in active addiction. We also really need to support folks who have lost someone to opioid addiction. Part is at least so beautifully talked about. This is something that just doesn't leave. And I think part of the issue is that you're grieving and it's hard to talk about. There is so much stigma. And so we really want to provide a supportive place for people to get the kind of, not only the support, the resources, and also to engage people in advocacy. So that is part of the answer. The other part of the answer is, okay, what do you do about overdose itself? This is a completely preventable thing. So I want to direct your attention to resources in the back if you haven't seen it yet. Okay, this piece of paper is called naloxone. This was printed by Walgreens, and this is included in a Walgreens Narcan kit. Walgreens, every single Walgreens in the state, you can walk in and get Narcan. You don't have to have a prescription, because Walgreens got into has a collaborative practice agreement with Dr. Jody Rich, who is also the prescribing doctor for PONY, which is the community naloxone distribution program. And that allows people to come in without a prescription, despite the fact that the naloxone is a prescribed medication. So basically, you go in, you just let the pharmacist know that you're interested in getting naloxone. They will need some information from you because it's a prescription. But a kit like this. This is an intramuscular administration of naloxone. You'll get a couple of intramuscular syringes, and you're also going to get 1 dose of naloxone. So 1 dose of naloxone should be enough to bring someone out of an overdose, but you actually get 2 doses just in case you need a second one. This kit right here costs $25, and it may be covered by your insurance. An intranasal kit looks a little different, but it also has 2 doses, has the exact same effect. It's, however, a little more expensive, and it's going to be about $48. And it may also, most of it may also be covered by your insurance. I'd also like to invite people to you're going to see this piece of paper right here. On one side of it is a bunch of links. And a really important one, if you just want to understand about opioids, you're like, I just don't, why are they so dangerous? You can check out Opioids 911. I'm not going to go through all the links, but this is a resource, just provides resources. But there's also a number on here, which I invite you to call, which is Community Access. That's part of the Miriam Hospital. I'm there every day except for Fridays. And that's where Pony is run out of. If you have questions, feel free to call me. If you have questions about naloxone, feel free to go to any Walgreens and ask the pharmacist. If you are unable to pay for naloxone, then you can come to Community Access and we can help you. So the number is on this. This side of it too, that says see an overdose, call 911 immediately. I just want to let folks know, the main way we have to save a life right now is calling 911. We want to distribute naloxone, and I think that is some of the terrific work that's happening in the state right now. There is a lot of efforts to distribute naloxone or get naloxone available, but right now most people don't have it. You have to call 911. And there was a Good Samaritan Overdose Prevention Act. Joan,
I just have a question on how much time do you have to administer when a person starts to overdose?
I didn't hear you.
How much time do you have to administer the Narcan
Oh, good.
when
Good.
someone starts?
So most overdoses don't happen right away. That was a great question. Most overdoses don't happen right away. They happen in 1 to 3 hours. So you have time. What you're going to see, and this is information that is, you don't have to remember this, it's on this piece of paper right here because this talks about how to recognize an overdose, how to prevent an overdose, and what to do in case of an overdose. So what will happen is an overdose means that you can't breathe. And so it starts with shallow breathing or gurgling noise. It sounds like snoring, because the person isn't able to get enough oxygen in their body. You'll see their fingernails or lips going purple or gray or blue. They will be unresponsive. If you try to wake the person up, they will not wake up. So those are, and then that's whenever you would call 911. That's when you would do rescue breathing. And if the rescue breathing doesn't bring them around, you would use the naloxone if you have it. When you call 911, you just have to let the operator know that the person isn't breathing. And we passed the Good Samaritan Overdose Prevention Act in 2012 specifically to get people to call 911 because there's a lot of fear. Many folks who use particularly use illicit opioids, have had run-ins with the law, and they're afraid to call 911. And so this was passed so that they would to lessen the fear of being arrested. So what does the law do? The law says that if you can't be prosecuted for possessing drugs. If you call 911 to save a life and you happen to have drugs on the scene, you can't be prosecuted for possessing drugs. It also means that if you have naloxone, whether it's prescribed to you or you got somebody else's, wherever that naloxone came from, you can use it and you will be protected from prosecution for civil or criminal liability. So it's a very important tool that we have. In fact, Rhode Island has really a lot of good tools. The important thing is to get the word out, which is what's so great here tonight. Okay, another couple of resources. In the back, there's actually StopOverdoseRI.org, www.noperi.org. These are Rhode Island sites. If you go to noperi.org, you're going to find out about naloxone, you're going to find out about the naloxone trainings, and if you want to get connected, if you want to tell your story, if you want to learn more about what's going on around overdoses in the state and what to do about overdose, you can go to StopOverdoseRI.org. These are great resources. They're brand new. We did not have these even a month ago. So this is really wonderful. So I think that is how these. If you are administered, so don't be afraid to administer naloxone, because naloxone only works on the receptors in your brain, your opioid receptors in the brain. So if you have opioids on those receptors, and that's what's causing you not be able to breathe, the naloxone, which is an opioid antagonist, literally goes in there and knocks those opioids off that receptor. So it brings the person around in a couple of minutes, and it only lasts 30 to 90 minutes, so it's very important that you get medical help on the scene. So even if you have naloxone, it's still very important to call 911. So these are things that you might not think about. If you have opioids in your home, prescription opioids, Elise talked about it. She had some opioids, they were prescribed to her, she didn't use them, she put them up in her cabinet, and they went flying, right? So don't let that happen. And one possibility is a lockbox, $9 at Walmart. And I mean, that's just where I bought it. That's where I could find it. So lock your meds. If you want more information, lockyourmeds.org. The other thing is, you might know exactly how many medications are in your cabinet, right? Because if you're taking medication for chronic pain, you've got them in your cabinet all the time, make sure that you know how much is in there. Because guess what? The drug dealers for prescription opioids are us. It's from our cabinets. If you talk to kids, 70% got their opioids, their pain that they used, the pain pills that they were using illicitly from friends and family members. So if you have any questions, we'll all still be here after the forum. Also, you will obviously have an opportunity to raise questions during the forum. But please take advantage of the resources in the back. Thank you very much.
So there's resources in the front too. Great panel up here of listeners. That's what they call it.
Absolutely.
In the organization here, a great panel of listeners. But now we want to hear from the audience. And as Dr. Fine pointed out, a startling stat: 7 ODs since Friday. That's 5 days. 7 ODs. And the faces of this problem in the audience. And now we're going to ask. I think Jim Gillen has the microphone. Is that right, Jim? Are you out there? Yes. So we're going to hear from the audience now. Questions, comments, answers.
Stretch your legs.
Everybody else can stand up. We will. And we were going over this. Would the audience like me to introduce the listening panel before or after the series of questions? Now? All right. It's going to take about an hour and a half. Not in any particular order. It's the order. Actually, you know what? It's in alphabetical order. Gerald Coyne in the front row there. He's a Deputy Attorney General in the Office of the Attorney General. He's been there quite a while. Colonel Hugh Clements, the Chief of Police in Providence, Rhode Island. Chief Clarence Cunha is the Chief of the Providence Fire Department. Stephen DeTroy is the Director of Government and Public Affairs for the Rhode Island Medical Society. Magistrate John Flynn is the Administrator and Magistrate of the Adult Drug Court, Superior Court of Rhode Island. Dr. Kathleen Hittner is the Health Insurance Commissioner, Office of the Health Insurance Commissioner. Chief Elwood Johnson is the Chief of Police with the Richmond Police Department and also President of the Rhode Island Police Chiefs Association. John Klusowski is the, did I get that right? Close enough. Is the resident agent in charge of the U.S. DEA. Leo LaViere is the pharmacy supervisor for Walgreens in Rhode Island. Senator Josh Miller from District 28 is the chairman of the Senate Health and Human Services Committee. Colonel Stephen O'Donnell is the head of the Rhode Island State Police. Jason Rhodes is the chief of the Division of Emergency Medical Services at the Rhode Island Department of Health. Dr. Christina Stanley is the chief medical examiner with the Office of the Medical Examiner in Rhode Island. Craig Stenning is the director of the Rhode Island Department of Behavioral Health, Developmental Disabilities and Hospitals. A.T. Wall is the director of the Rhode Island Department of Corrections. Dr. Jason Hack is with toxicology and emergency medicine at the Miriam Hospital. So now we're going to hear from the audience, questions, comments, personal stories. And Jim will be picking the commenters, so look his way.
You all set, sir? Okay. My name is Angel Corporal Brown.
Angel, and one more, and I should say this, I've been told to keep the comments down to 2 to 3 minutes.
That's beautiful.
So don't blame the messenger.
Don't worry about it.
Okay.
I'm a public speaker, so I know how minutes go quick. I'm Angel Corporal Brown from the Providence School Department. I just lost my niece January 12th from heroin. You can pass it around. 20 years old. 2 weeks ago, we just lost another cousin to OD. Joni right there, she's from the school department too. She actually worked with my niece as well. My niece went to the hospital 3 weeks before, no, maybe a week before she passed away. I guess from a head injury from when she fell doing the heroin, which I was not aware of. The hospital called me on a Saturday about 2:30 in the afternoon and said that she was in critical condition in the ICU. She died that Sunday morning about 3:23. I was not aware of the heroin that is laced. I found out recently, in January, 22 people died, and then in February, 16 more had died. So I would just like to know, what are we doing about it? Because 20 years old is too young, and a 44-year-old is still too young. So we really need to get on the ball concerning people dying, families dying. Amen? I'm a pastor as well, so.
All right, bring it on, come on.
Elise, thank you for sharing your story. My name is Debbie, and I lost my son Sebastian October 6, 2010 to heroin, as my friends here have lost sons of life. I'm originally from Massachusetts. My son spent a lot of time in Massachusetts because he was able to get health care there. At that point, we didn't have it here. The day after my son passed away, he had been in a shelter. I called the counselor to let her know, and she said to me, by the way, there's this group, Learn to Cope. She told me after he had passed away. And I so appreciate that. As a parent, such a stigma to it, you feel for them, because it's not a life anybody would want. But there's so many questions that parents have, and yet you tend to try to take care of it by yourself. You don't really get yourself to other people. And to me, I so appreciate you having this group. That's where I'd like to help out, because I think parents should have a group to go to. It's the same way if you want to lose weight, you know about Weight Watchers. If you want your taxes done, you go to H&R Block. But there has to be something that parents know immediately. If they suspect their child is into drugs, they need to have a place to go, a resource to go to. It's just so much bigger than any one person.
Hi, my name is Michael Rossi. You guys can hear me. I just happen to be a registered nurse, psychiatric nurse. I just happen to be managing a while back a recovery house, and I just happened to come home. And me and I just happened to see Jonathan's door open. And he had overdosed. I came upstairs, I called 911. Told them to bring a Narcan kit, naloxone. And immediately realized, wait a minute, I had some. I just happened to have some in the house. And I went downstairs and I got it, and I gave Jonathan an injection. He was barely breathing. His lips were blue. His fingers were blue. He was foaming at the mouth. I gave him an injection, not as a nurse, as a human being. I gave him an injection not because it took great technical skill. It's easy to use a needle when someone's life is slipping away. Trust me. 911, I heard the EMTs coming up the stairs. It was the 3rd floor. And I looked, he stopped breathing. So I gave him another injection. He started breathing, after that, very shallow, and it just didn't look it. By the time they got him downstairs, he came to like that. Almost as lucid as I am now. Because the first thing he said was, he looked around, saw the ambulance, saw me, and had the wherewithal to say, do I have time for a cigarette? So when someone asks for a cigarette, you know they're pretty much going to be okay. I think the message that I would give to this panel is that all those coincidences, just happening to be home, just happening to be in the morning, just happening to be on Earth and be able to think of my feet, just happening to have me to come home, just happening, why he had the door open, I'm still clueless about. No one does that, trust me. All those coincidences, miracles, would have been wasted if one person hadn't decided to make sure there was a kid in that house. So I think, in my view, my humble, heartfelt view, they should be as ubiquitous as fire extinguishers. And anywhere there's any likelihood of someone overdosing on prescriptions, heroin, whatever it may be. So that's my story. That's some good news. And since then, Jonathan can tell you what he's been doing and how one life saved can lead to another one, and families can be put back together. That's the importance of the message that I would like to share.
You worked on that line, I think.
I still owe my coffee. So I've suffered from heroin addiction for many years, and I'm thinking, my God, if you ever told me years ago I'd be in front of the presence of law enforcement addiction, I would have been in trouble. But it's nice to be here in contact with the rather than the problem. So I've struggled with addiction for years, drug and alcohol addiction, and my story was that I relapsed in a recovery house. And if it weren't for Mike as an individual, as we said, having Mike in there, I would have overdosed, and I truly believe I would have died. Since then, I've been cleaning drugs and alcohol since June 17th of last year. I work for a nonprofit organization, Project Weber, funded through the Department of Health, which is a peer support program specializing in harm reduction. And I've myself become trained to administer Narcan, or as Mike would call it, my poetic justice training. And I know that we as an organization, and me as an individual, do everything we can with Narcan, naloxone, and I'm all for advocating for it, because I wouldn't be standing here today in this room if it weren't for it. Thank you.
Good evening, I'm Eileen Hayes, I'm the director of Amos House, and first of all, I want to say that my heart and my prayers bless all the family members here who have lost loved ones. I've been thinking, as I'm sitting here, about all of us who are caregivers. We've lost, in the last 3 weeks, 2 members of our community died from heroin overdoses. One was Charles Brown, and we were really sad, and the other was James Brown, who was 24 years old. And what I want to say is that we go to these funerals. I've been to many over 13 years ago in this house, and unfortunately, people show up and it's like, oh, there's another one, there's another one, there's another one. And we're almost getting too complacent about there's another one. And people get immune, partly because it's so overwhelming to bear it. And I'd like us to think about how we can help the caregivers, because all of us who are doing this work, all of my staff, every day are suffering from vicarious traumatization and still having to show up the next day and the next night and the next day and the next night. And so when we're talking about all the different people that need help, and I think our caregivers also need to have some attention paid to the enormous work it is for us and for how hard it is, because we care about the people who are dying. Thank you.
Amos House, a jewel in the community, unbelievable research.
Hi, my name is Dennis Dutra. I'm a person in long-term recovery. What that means for me is I haven't used drugs and alcohol since May 17, 2011. Statistics show that people leaving incarceration are at the highest risk for drug overdose. I was wondering what can be done to implement procedure to educate and supply people leaving incarceration with naloxone training and naloxone. In every facility, for every person leaving incarceration, not only sentenced individuals, but also people awaiting trial and people getting out on bail. I happen to know from a reliable source that when someone leaves on bail from the ACI, they sit around in a cell for about 2 hours doing absolutely nothing. That would be an excellent time to show them a video, teach them naloxone training, and they can be provided with naloxone on the way out the door, and that can save lives. So I was just wondering if that can be implemented. Thank you very much.
Thank you so much, everyone, for coming here, and my heart too goes out to people here who have a loved one who struggles with this or who has passed away from this. I'm Dr. Kathleen Carter. We provide treatment not so much for opioid as the primary piece, but we do other substance use addiction. But what I did here tonight, which I will always talk on, everybody knows this, mental health services too are so important, because anyone I've met, and we do treat people who have an opioid in recovery, I'm not the provider for that particular piece, but we do work with families, we do work with the individuals around mental health, as well as interpersonal violence. 40 to 60% of the time, there's an interpersonal violence, and the rest of that, there's some substance use going on. 83% of the time when there's substance use, there's a mental health problem. It doesn't mean that people are crazy. They're depressed, they're anxious, they have bipolar illness, it's untreated, PTSD. And I think we need to, and it's not hard to do. I work with other providers, because I'm not a genius. I'm pretty good, but I'm not a genius. And so I work with other providers. If they're in a treatment program for Suboxone, if they're in a treatment program for methadone, we're in contact with them. We make sure that they're doing what they need to be doing, we're doing what we need to be doing. And it's a very easy process, as long as we're open to be able to do it. And we have had pieces, people, family members talking. It was really difficult for us to get family members in. And really it was, we gathered people from any treatment site, didn't matter, it didn't have to be a my company. On Saturdays for a couple of hours, it was like 2 to 4 hours. This is what treatment is. This is what you might expect. These are other resources. I don't have all the answers, but it was a place where people would talk about their brother, their sister, their mom, their dad, alive or not. And it was a pretty remarkable experience. But it's tough to get people to be able to come in. I think you're right, because of the stigma. But anyway, I would like to see us be able to do things like you said, Dennis, of pulling people aside and saying, here's some information. You know, you don't have to use it, but we're going to give it to you anyway. As well as to incorporate mental health, other substance use, as well as interpersonal violence. They're 3 inextricably linked pieces. And thank you again for your time.
Hi, everyone. Hi. So my name's Maddie. I worked last year with Tracy and Dr. Green, Dr. Rich, Sarah Michelle, and we did, I don't know how to say this. Like this? It's not working. I can hear you. It's not. Okay, so we worked on a project training folks, getting I just wanted to offer one quick snapshot, which is, I think it was November 1st of a year and a half ago. November 1st, the first of the month, is a big day for people getting released from the ACI. I sat in the front lobby at men's minimum. I had, I think, 7 packages of naloxone, and I just sat and waited. It was 1 p.m., and the guys were getting out, and I
driver of Rhode Island registration
out the naloxone to each person as they got out, and that was 7 doses.
Driver of Rhode Island registration
I forget how many got used, but it was, I think, at least 1. So that was a snapshot. We should be doing that more.
Hello, my name is Sarah Bowman, at Rhode Island Hospital. I wanted to thank the panelists and everyone who's come to listen tonight. I think that there are many faces in this room, some who may be at their first community overdose meeting or event, and it's awesome to see so many people I don't know. Also really nice to see people who have been having a lot of different meetings over the last months and years to all be at the same place. I hope that tonight really serves as kind of a call to continue putting the teeth behind, the movement behind so much that we've been talking about over these last few months. I want to applaud the HPDH for coming out with an emergency regulation that is changing things so quickly and that is going to go into effect so quickly. I hope we'll see that play out smoothly in the coming weeks and months. I think that there are probably many of the people in the room tonight who need to be at the table when we're having conversations around how to change the regulations that make it harder to access naloxone as a prescription medication, that perhaps hold some of the purse strings to the money that may or may not be available to pay for Narcan, to put into the hands of the individuals who are in this room and the people that we know. I think that we need to do everything that we can to leverage the increasing access to naloxone to be paid for by insurance, since pretty much everyone is now paying for intramuscular, and they're having the conversations with the last holdouts on intranasal to have that covered as well. But walking into the pharmacy isn't going to be an option for everybody. Being able to walk in the door, Pony, and have the conversation with the person who pulled you in off the street to talk about overdose prevention, for that person to then be able to give you the kit, and for that to be not only Michelle and her volunteers who come out of community access and are doing that one place, but for that to be the drug treatment centers across the state, for that to be community-based organizations across the street, for that to be people in more than one neighborhood and more than one place that can have that conversation with people that they know, and then through whatever mechanism that we can figure out for this medication that is so safe and people understand so reasonable, but we still have to figure out the bits and pieces to make our systems and our regulations and our funding all fall into place to support the momentum and the conversations that we're having. So I hope that tonight and the new faces and the old faces that are in this room are able to really put the motivation behind those conversations in the days and weeks to come to make that happen. I think that people are watching and are ready for that. I also, change gears, have remarks from somebody who wanted their words heard tonight but didn't yet feel comfortable getting up to share their story themselves. I could read this and you could change your mind. You could still grab the mic a little bit. So these are their words. I'd like to commend all involved in making this process of getting detoxed easier for the addict. My question, commentary, is what is being done to help the addict learn to live with their disease? The process of leaving detox begins the day the addict arrives. Once detoxed, they usually go back to the same life that they had before, with few new coping skills. Most addicts are dual diagnosis, yet rarely get treatment and counseling for that. Now that the problem of addiction has been brought to the forefront, I hope these issues will be addressed, because the ideal goal should be long-term counseling and skill development to reject drugs in their day-to-day life and live a happy, productive lifestyle. So thank you all.
Hi, I'm Peter.
Oh, go ahead.
Testing. Hi, I'm Peter Friedman. I'm a physician, medicine physician in Providence, and a researcher. And my heart also goes out to the families affected by this horrible disease. My question is a little bit of a radical one. We've been talking about Narcan, and we've been talking about trying to reach people who are reachable, but clearly there are a lot of people out there who are continuing to use and are not ready to sort of hear the message. And I guess the question I have relates to experience in Europe, in which there are safe injection rooms, sites that actually have medical personnel on site or trained personnel. who are able to act in case of overdose, places where individuals who are actively using can go safely and do what they need to do with access to clean paraphernalia, etc., and medical personnel. And I guess my question is, at what point will we in Rhode Island and in North America, actually there are already some sites in Canada that are doing this, but at what point in the United States and in Rhode Island are we going to be ready to consider this as a way to address this epidemic?
I'm a licensed clinical social worker, and I work with
It's on, it's on.
Hi. No.
Yeah, you might have to yell. We have that one, yeah.
While we have a moment, as you ask your questions, I just want to give you a heads up that I am writing them down so we can direct them to the panel after everybody's done.
Hello? Hi, my name is Valerie Palermo. I'm a licensed clinical social worker, and I work with a doctor who provides spots. And also, my own 28-year-old son was told that on Thanksgiving Day, when he got a heroin overdose. However, I received a call from the medical examiner's office 2 weeks ago, saying that they found pure fentanyl. He judges by heroin, he was so fentanyl. My local police department called me, I couldn't just go ask me for any information. I gave them the address. I know who the person was. I know that 400 people were sold throughout the same person on that day. None of them died, none of them got well. It was my understanding that was turned over to the DEA as an investigation. I made several phone calls to them. I was just wondering, am I not picking up any of that information? Or does the people really have a right to know what's going on if I have more information to give? I'm just wondering why, how it works when people do the investigation. I don't know anything about that. So nothing's been making some of that.
I'm trying to just spread it around. Hands? Okay, I just want to get a couple folks on this side, and we'll get back in the interest of fair play.
Hi, everybody. My name is Jonathan Jacobs. I just have some issues. I know that so many of these issues end up turning into conversations about dollars and cents. And you know what I see right now, and members of the press who are here, please PolitiFact me on this if I'm wrong, but some cursory numbers that I've looked at show that the governor's budget proposal for fiscal year 2015 reduces DDH, behavioral health funding, by almost $8 million from fiscal year 14's amended, and almost $10 million from fiscal year 13's audited. So that's approximately 77% federal appropriations, and the remainder is state appropriations. What do we do to make up for those lost funds? I mean, these are funds that would be going to help behavioral health issues, this being one of the biggest, and these are things that are interconnected, interlinked. I mean, mental illness, behavioral health issues tend to all be a holistic amalgamation, so that when we look at issues like substance abuse, we're looking at how do we fund prevention, how do we fund behavioral health treatment, and hopefully we can avoid having to use things like naloxone as often. We could avoid having to rectify overdoses when they're actually occurring if we can try and take the time to get the money appropriated where it should go to prevent these things. So that's my question. Where is that money going to come from? And if my numbers are wrong, please, find that out and point it out. But I'm pretty sure they're right because they can't write it in the governor's budget. Thank you.
Hi,
Hi, my name is Neil Corkery, and I'm not going to tell you what I've done. I'm going to tell you who I am. It may shed some light on this. I'm a person who has, in July, if I live that long, I've retired finally, will have 40 years of sobriety. But I'm one of the lucky ones, and I think we're talking about a lot of people who are not fortunate. If it weren't for some spiritual awakening that happened, and I saw a nice article about Dr. Recupero recently talking about spirituality, I think that it's our lives that we're all screwed up. It's not just that we suggest something in it. We're different. I think differently than you, or a normal person. Must forget somehow. I'm being very open about this. You put a bunch of us in a place together, we'll screw it up. We'll have you dizzy. Frank knows that. But some people need a wake-up call, and I had a wake-up call through that, and a wife who's strong and a wonderful mother who gave me an ultimatum: either you get treatment or you get out. And that's, I was fortunate. I got into treatment with Dr. Capone, that many of the psychiatrists here may remember. He's dead now. He's a wonderful man. I was so nervous. I started smoking. I mean, I felt like the lowest low. There's shame associated with this. There's all kinds of tragedies in the family. It's still a stigma. I hate to say it, but it is. And there are some of us, people have known I'm in recovery, so it doesn't bother me. And if I can help people, I try to help. And Jim is in recovery, and Ian, who worked with me. I mean, they're great examples. And Steve is also. But we are fortunate. Not everybody gets it. It's a chronic, relapsing disease. I found that out. I still go to meetings. I'm the Duncan Hines of therapists. I've been to family review, and I've been to marriage counseling. Even sober, there are days you don't want to be around me, maybe. I don't know. But I've lost a son to this disease. But I have another son who's sober, 6 years. And I have a grandson who's sober 2 years. I just tell regular people that. They say, well, geez, what's he doing? They're all nuts. I'm just thankful, because they do have a disease. And so I think, I want to say a tremendous thank you for Jim, Craig, and the department. Dr. Fine was on this 2 years ago. He had where's my friend from the psychologist that I always get? She's, remember, I still live there. I do go up with the memory problem. She's done more work on this because it's a different thing. I remember the 80s when cocaine was the big thing. I said to people in the legislature, we did about a 6-month play. They did. So I give you credit, and all of these people in the audience that came. You know what I don't see a lot of? If this were the British go on activity, what's this kind of a bridge? Be full of politicians here. It's still not a big issue. He's the exception. Harry Miller, he's what you see is what you get with him.
I hate to cut you off when you're criticizing politicians. I hate to cut you off. But you're at 3:30.
There's a agent here who's running for mayor. Just want to thank all the people who gave their time. You got to keep doing it, and you got to get at the political structure. They make the budgets.
Hello, everyone. My name is Pam Shear, and I'm a registered nurse. I work at Butler Hospital, and I also am the director of assisted recovery at Suboxone Clinic in Cranston. And I feel for all the people in here who have expressed their tears and their emotions, because I've worked in recovery for about 25 to 30 years, so I understand how, what you're going through. But I just wanted to say, as far as the distribution of naloxone in the community, I do have some reservation about that. And the reservation that I have is that those addicts that are in the community right now, I don't want them to feel a false sense of security, being that it takes time for things to get distributed in the community. It takes time for this to even happen. So if the addicts in the community who are not under treatment, if they go through and they decide that they're going to, shoot up X, Y, and Z, and somebody's going to be there to save them, that could be a false sense of security, knowing that somebody might just be there for that. So, that's just one point that I wanted to kind of, put out there so that we could think about that. Although I understand that family members and friends, might be there for them, but on the street, things can really happen, and I think that's where the treatment really needs to be. I think those in treatment with Suboxone and with methadone, and giving them naloxone is almost, to me, like telling them, well, if you fail, that's okay because there's something there for you to fall back on. If somebody really wants to be committed to Suboxone and methadone, and that works for them.
Good evening. My name is George, and I'm a person in long-term recovery. And what that means for me is that since July 27, 2010, I haven't had a need to use drugs or alcohol. And because of that, my leg's gotten... I don't go to prison no more. I can sit in the same room with officers of the law and shake their hands, and I live a pretty good life today. I work for Anchor Recovery Community Center, which is we're a peer-to-peer support services. And besides the naloxone and all that, I want to say that I'm also a certified recovery coach. I believe that our services have become very important in recovery process, and I think more people need to know that what we are and what we do, because most people can relate to me. I spent half of my life in a prison cell, okay? Today I'm out here and I try to help people, and I have a lot of people who come to me and say, I can't believe that you are where you are. And I can guide them a little better than somebody that has never been in recovery. And, so don't be afraid to send them. If you know them, send them to Anchor Recovery. We're in Pawtucket and Warwick, and we don't deny nobody the services. And, I love it. Thank you.
We have two more questions.
My name is Kim Rosen. I'm here as a mom. I too have quite a few years of recovery. It'll be 20 years soon. I don't really want to talk because I'm here as a mom. I'm here because I lost my son 11 days ago. He's being buried tomorrow. And I read in the paper that the state police are going to stop carrying Narcan. But my question is, what about the municipal police? My son, I'm from Woonsocket, and I'm not saying that would have changed anything, but maybe for the next one, a lot of times the police get there before EMS. So I think, being here as a mom, I couldn't save my son from this addiction. He had a year clean. As of Christmas, something happened between Christmas and now. I just want to put out there that it's important for everybody to be aware of this disease. It sucks. That's the only thing I can say. It sucks.
We have time for one more question.
Hi, I'm Frank Nolan. I work for House of First Riverwood Mental Health. I'm a street outreach worker. I'm out on the street 7 nights a week, and 7 days. My area goes from Wakefield to Foster and then over to the Massachusetts line. So you see me everywhere. We're always asked, if you come across someone that's OD, what do you do? Call 911. That's all we can do. But sometimes it might be too late. So we're going to have a meeting. We have a meeting once a month. And those that you know me, I'm pretty thick-headed Irishman, and I'm going to say on March 3rd, and I'm going to suggest that we get trained in Narcan, and we use it on the streets. Because if we can save one life, that's one life better than none.
So I counted about 20 questions, and I'm going to go over these, and, panel, please step up, and I can come up with one. I think let's start, because I know A.T. Wall would probably be able to address this one, so we can start with A.T. Wall. There was one question, if I can find it. What can be done, and somebody else might be able to chime in on this too, what can be done to help addicts as they leave the ACI, after they leave the ACI? That was asked by Dennis Dutro.
Who would answer that?
I think it's fair to say that I've been part of the great evolution of the corrections profession over many years. I got my start about 37 years ago and still working in corrections. And we traditionally thought of the offender population as people whose behavior was product of the criminal mind. But over the years, what we've discovered is that in a great many instances, it's the product of disease. It's a public health issue. And the evidence is that about 70% of our population suffers from that disease. And Dennis, you asked what we're doing about it. A couple of things I wanted to let you know. One is that we do have Narcan behind the walls in every one of our institutions. People trained to use it and ready to use it. And since they're first responders, when somebody overdoses inside, it's a very important feature. Recovery has been a great gift to us, the recovery movement, because people who have conquered what you have conquered have a credibility that we, the professionals in corrections, are never going to enjoy. And that has been a wonderful development for those of us who really do want to see people make progress. Many people do become clean and sober behind the walls, but your point is well taken, Dennis. The moment when they leave, but hours, days, weeks, immediately after release, they are very vulnerable. And indeed, we have some staff in the women's facilities who scan the media and can identify the number of women over the weeks and months who have overdosed following their release from the ACI. I think that we can ramp it up, and we're going to need to do so. We have a pilot project going with Dr. Rich and his colleagues about providing Suboxone to inmates as they are preparing for and getting released. We also think need to provide more in the way of education. I would like to see the kinds of materials that we are getting tonight readily available behind the walls. I'm intrigued by, Dennis, by your idea of a video that could be shown to people getting out, being prepared. And I think there's a real opportunity with our probation and parole offices. 22,000 people in Rhode Island are on the street under the Corrections Department's supervision following release from the ACI. That's 1 in every 21 men in the state on any given day. And our probation and parole offices are where they report and where staff who are trained to recognize certain symptoms and give out certain materials can, I think, make a tremendous difference. And I think that's the next frontier for us, is paying attention to what happens at the moment of release and harnessing the energy of our probation and parole officers so that they can become, as it were, agents of public health as well as agents of public safety. Thank you.
So let's start at the beginning. We heard from Angel, who lost 2 children to overdoses. And I think she asked a question looking for awareness. She wasn't aware that these types of drugs are out there. Maybe that's a question I should answer as far as awareness, but perhaps somebody on the panel can talk about you know, why it took her losing 2 children before she was actually aware that this stuff was out there. Volunteers.
Put the guy in a great suit.
I was going to suggest it.
How did I know you were coming my way? So I come here tonight with some mixed emotions. I'm thrilled that we all came together, and there's this many people in the room, and we have people from various aspects of this problem. However, it's difficult for me to look at the number of people who have passed away. I spent, some of you know, before I joined the state, I spent 28 years running a treatment agency. And I used to say it was the best job anyone could have because I got to enjoy the beautiful journey to recovery that many people enjoyed. So I got to work with a lot of successes, and there were people in this room that began in treatment at that agency. But this has been extremely difficult to see this many overdoses in this short period of time. And to realize that we haven't overcome the stigma of addiction. It's difficult for me to believe that after 40 years, 50 years, that there are still people who have the kind of attitudes that some people still have. If you go on my Facebook page, you can figure it out. The stories that I put up there that talk about some of the successes, or Anchor and the recovery and going to the certification of recovery coaches, I get a lot of likes on it. But when I put up the articles about the overdoses in this forum and the press conference that Dr. Fine and I had last week, some of the comments are extremely difficult to read. Neil used the word shame. It's that very attitude that keeps people from entering treatment. It's the shame, it's the stigma, and addiction is very isolating. You lose your family support. You lose the community. The beauty of recovery, the beauty of Anchor, the beauty of this kind of a grouping is that there are plenty of people in recovery that now form a community of support. The road through treatment is not an easy one. Addiction is difficult. And many times you hear, well, people, they went into 3 different programs, and people are kind of cynical about that. It's difficult. But the more we can surround it with a community of recovery, and as Becky mentioned, we have the tools in Rhode Island right now to beat this. Overdoses are preventable. We have an increased access to treatment, and I can quickly answer the question about the budget. No, there wasn't an $8 million cut to treatment. What that was under the Affordable Care Act, the individuals who were uninsured, who we used to pay for half of the cost of that treatment, is now covered under the Affordable Care Act, under Obamacare. So those dollars are shifted out of our budget into the Medicaid budget. So it was a shift of funding, it wasn't a cut to treatment. So we have access to treatment. We have a larger distribution of Narcan. I thank you for the comments about the emergency regulations. It's only the second time in the history of my department that we ever used that tool. I haven't been challenged on it yet. The training is being provided in the next 2 weeks. That's pretty quick for state government. And it does apply to any treatment agency that's licensed by us. But it's really designed for residential treatment facilities, detox facilities, people coming out of the hospital, people coming out of the ACI, because one of the biggest risk factors is tolerance. So for those people that maybe have been trying to get clean, and they've succeeded for 2 or 3 months, and now they slip, or they've been in the hospital, or they've been in a detox, they come out, much more likely to overdose because their tolerance is down, and the stuff that's out there is that much stronger. So if you're talking about fentanyl, even if you had a high tolerance, you're going to overdose. But if your tolerance has been decreased, the chances are you will overdose. I don't even remember what the question was.
It was along those lines. She was actually asking why the information about that wasn't out there. I think it was, but
In the school, put it
in the school.
Yeah, you know, we have a number of community prevention organizations throughout the state. There are 30-some odd community prevention task forces. They need to concentrate on this. We've been doing a lot of work on some other issues. And there's a lot of discussion around what particular drug, should it be legalized, shouldn't it be, you know, should it be offered for medical purposes. That has taken so much attention away from what the real problem is, and it gives the illusion that perhaps drugs aren't that dangerous.
We can hold another forum on that one, I think. So Kim, who amazingly is in this room and lost a child 11 days ago. 11 days ago. She's in Woonsocket, and I think perhaps Chief Johnson might be able to answer this or address it. She talked about, will other city police departments have Narcan in their cars? And maybe that's been talked about among the police chiefs in the state.
It really has not to date, but I can tell you that Colonel O'Donnell and I are classmates in the state police in 1986, and he always liked to be first at everything. I don't know whether it's not the fine idea to partner with the state police for that media splash, but he did give me a courtesy call and said, hey, you may be getting calls on this. Like anything else with a police department, I'm the president of the Rhode Island Police Chiefs Association as of January. In my inaugural address, I actually talked about the overdose epidemic. We see it in the communities, and you mentioned a very good fact, and that is police are often there before the rescues, and it's because rescues are situated at a rescue facility, police are on patrol, and they happen to be near those addresses where those calls come in. And I can tell you from the first-hand experience of a lieutenant that went to an overdose. Can you hear me okay back there?
Yes.
Okay. I know we've had some problems with this and the lights. He was there before the rescue for 8 minutes. And when he walked up to the front door of the house, the mother came out and said, my son is effing dead. This is a drug house that we've been to a number of times, and it was a person in the mid-30s, poor breathing, or no vital signs, and there was complete chaos. And he started to perform chest compression, just praying that the rescue was going to get there. He never got him to respond, but he kept the blood circulating, and obviously when you do chest compression, you get respiratory response as well. When they walked in from the rescue, they gave him a shot of Narcan, he sat right up. And then they refused to go in the rescue because they wanted to watch the Patriots playoff. Lieutenant, I just performed CPR, my pants are filthy, you're going in the rescue for a ride, and you're checked out. Long story short is this. First of all, very sorry for your loss. I can't even imagine. And the reality is, whether you have an addiction to drugs, or you have some other fatal illness, or you're dealing with some life-altering, challenging, whatever it is, I mean, we're there to serve you, and you're not to be thrown away. There are people that mean harm, and then there are people that just do harm to themselves because they're trying to cope with something that they're having a difficult time with. And that's why they turn to drugs and alcohol. Sometimes it's recreational, that's how they get introduced to it, and then they look to it because of those things that attach to your brain that say it's not as bad as you think it is. The problem is this fentanyl right now is becoming an epidemic itself. The DEA is aware of it. You know, I can get to that other question that was raised by a mother who lost a child as well. Education in the schools is very important because that's where a lot of this stuff is starting. And those are in our communities. We have school resource officers that are great resources to the kids in these schools. And they have tons of information that can be made available, but they've got to get a uniform message. And that's part of the beauty of this forum. I can tell you this, no matter what the problem is, the challenges of society, the multidimensional approach that you have is always going to be the best response. Law enforcement's never going to have the answer over. Medical professionals aren't going to have the answer over. It's going to take all of us to address these. But as far as, I'm not trying to avoid your question, I would like to think that we have Narcan available to each municipality in the state. It's going to be up to those individual municipalities whether they want to carry that or not. But it's like everything else on my belt that pulls my pants down. It's a resource and a tool, right? You don't know. I hope you never get that call. But I would much rather give somebody a nasal spray of that particular drug, Narcan or Naloxone, and have them pop up like that and want to watch a Patriots game versus doing chest compressions, hoping that you don't lose it. Have I answered that question?
And I was asked to introduce, you don't need an introduction, right?
Hugh Clements, Providence. I just wanted to add to that, President Johnson. We actively have spoken about that in Providence, about carrying it, and it was prompted prior to an interview I did with Kristen from Public Radio a couple of weeks ago. She's doing the big special on this issue, and she's ahead of the curve on it. But absolutely, we really need to look at this holistically, of prevention, intervention, treatment, and enforcement. And from the enforcement side, I can tell you, I'm sure DEA will expound on it, but there's a lot going on behind the scenes, and we need your help on the enforcement end as well. We need phones, we need phone numbers. We try to get the dealers, the street dealers, and climb the ladder. And to climb the ladder, it's a very engaging process to make an investigation and to make a case, and that's what we're actively looking to do. But very important, we really need to look at this, again, comprehensively. It's not only the enforcement piece that we're looking at. So I can tell you in Providence, we're ready to carry Narcan. There is a cost, there is a training factor to it, so certainly we need to navigate through that. I will say that when the 911 call comes in, we have a separate communications division. So the call goes into the communication side, and it goes right to fire, which Chief Cunha was prepared to speak about. So all of those 911 calls go directly to fire, and they administer this over the years several times. But I think it is important for the families, and our heart goes out to the families and the community. This is an epidemic, and we're looking into our heart.
We didn't get any specific questions about enforcement, but maybe we can talk about that now. Maybe Colonel O'Donnell or the representative from the DEA just talk to us about what they're seeing and maybe what could help.
Sure, I'll be quick. I just want to thank Dr. Fine. I think it goes without saying that he's been on this for a long time. He's the one who knocked on my door about a year ago and talked to me about this as a statewide issue, and then bringing Craig into it also last week talking about this. And also thanking Walgreens, who is a community partner of ours, who talks to us about giving gifts to kids at Christmas, things like that. And the first person we thought was them when it came to Narcan. And not having no knowledge that Walgreens already gave it out to us, first thing that Ralph said to me. So I want to thank those three publicly. How I look at this problem is it's a multi-tiered approach. I hear you loud and clear. The parents who hear, I don't know how you can do that, stand here and say you lost a child. I can't even fathom going through that. From first responders to overdoses, to traffic accidents, to whatever it may be. Education, I think, is the key. One of the young ladies in the back was talking about, how do I know about it? Oh, in the schools, the teachers. This is not a police problem. This is not a Walgreens problem, Dr. Fine problem, or a legislative problem as much as an education problem. Make people aware of it. I think we take for granted. They think, I heard Craig loud and clear, that they think it's not that bad. I hear that. I coach in a high school. I hear high school kids tell me all the time, it's not a big deal, coach. Oh, it is a big deal. And you have responsibility as a mother, father, parent, whatever, to tell them. The gentleman here, I'll guarantee you, you're going to tell me it's a problem, right? And I'll guarantee every issue you have in your life with law enforcement is based on drugs. That drug leads to that desire. And I worked undercover for a long time. And I bought heroin for 6 years. Never used it. And I can tell you the people I dealt with, the ultimate power to get that drug would drive them to rob a store, to break into a house, do a home invasion. So it's a systemic issue that crushes cops across the street. So when they're coming in to arrest somebody, it's usually based on something happening that leads to a crime. I know you guys know that. The education piece, Colonel Clements talked about the enforcement piece. It's there. When you see this, uniforms, people are want, oh, you said the same thing, it's pretty clear. Well, we are your friends. And you know that. But when you're selling that stuff, you're not our friends. Because you're giving poison to people. And here we are with 45 people dead in 2 months. That's outrageous. We talked about homicides last year, Rhode Island, 30. We have 45 people dead in 2 months, not even 2 months. So when are we going to get that message where we educate, reinforce, we go after that drug trafficking organizations? As Huey said, climb that ladder, go after those drug dealers. And then what do we do with that? Sometimes they get incarcerated, sometimes they get sober, sometimes they get the message the hard way. And we continue to educate and talk to people.
and then you have the recovery piece. You have to get people to help, know you're available to them. I can't think of a better advocate than you. Then they've done that talking to somebody. That has much more effectiveness, no offense to our clinicians, but when you're there, you're telling somebody, they get the message better. We need more people like you to get jobs like that. And the final piece, when we talked about Narcan, the doctor talked to me about it last week, about going to use it, and we are going to, one way or another, put it in our cruises. How does that affect your local P's? Well, us, troopers everywhere. They might not be the first call for service everywhere you go, but I want to make sure they have that. We also have sheriffs that fall under my authority. There's cell blocks. Where do they go when they get arrested? Right in those cell blocks. We want to put it there in our Capitol Police. Thank you.
Thank you.
So, RN from Butler, Cam Shear? Cam?
Pamela.
Pamela.
Close.
That wasn't even close. She asked it, perhaps one of the clinicians, or we have a doctor of toxicology from the hospital here. She has reservations as an RN at Butler about naloxone. Reservations about naloxone. Any discussion about that? The discussion about whether or not that should be out there.
So, putting an antidote into a population is a scary thing. You might interpret it as being a medicine. And we're used to, and our comfort level is that a physician will administer a medicine. But think about what the alternative is. The alternative is that people die. People die. So I think they'll always be daredevils. So cases like some people are concerned about may happen. But the broader good, I think, 1 life saved, 10 lives saved, 45 lives saved, is worth it. I'm also a medical toxicologist. The Narcan itself, naloxone itself, is a perfect molecule for the morphine receptors in the brain. It binds with much higher affinity to the receptor than heroin or any of the prescription opioids do, and it turns it off almost immediately. It has almost no, most people would say, abuse potential, and it works only for the opioids. So if something else is going on, it's not going to cloud the picture. It's not going to cause them to be in jeopardy. If they're suffering from an opioid overdose, it turns it off. It will get them breathing, and that's what you need to save somebody's life.
Okay, next question.
But I just want to say that I have concerns about the idea that giving somebody naloxone is going to encourage a relapse. And it's a dangerous thought to have that. And just say that, I'm a cancer survivor. I'm hoping that I don't get cancer again, but it doesn't mean that I don't pay attention to what I need to do. We know that addiction is a chronic relapsing disease. And while we have people in treatment, we hope that they won't relapse, but it doesn't mean that we don't give them the tools to address that if they do. And naloxone is really important to people have. It's not going to trigger a relapse. Having naloxone is not going to trigger a relapse. It's not going to be the cause for somebody to go out and use. I'm not going to say, I'm going to go use because I have naloxone. It's not likely. If we give people needles walking out the door when they're coming out of residential or detox, might that trigger a relapse? Maybe. Which is why we really want to make sure that we're working to get people the intranasal naloxone as opposed to giving people needles on the way out. But I really, my opinion, giving somebody naloxone when they're in treatment is a good idea, not a bad idea, and it's something that might save their life.
This next question might be good for Gerald Coyne. We had a mother, she is her son was arrested. I'm looking for the name in my bad notes. Her son was arrested, and you might remember the question. She's wondering, is she going to be privy to some of the details around that arrest? And I believe it's a drug charge.
I
it was the question, if I recall, was that your son had died, and the question is, at what point will you be made privy to the investigation?
Right, right. I
And
was told the medication in the case caused the death from accident, overdose, or whatever. Because they consider a homicide, I guess.
Well, I will echo some of the comments others have made, particularly Colonel Providence. This is a very high priority for law enforcement, but it is a priority that is complex enough that's being worked on at the local level, the state level, actually by the DEA, who has taken a major role in this because it is a much greater problem than Rhode Island alone. So I can assure you that as a prosecutor, when we have credible information to share with you at the appropriate time, you will be made privy to it. I think the last thing everybody in this room would want is for an investigation of something this important to be compromised because information was shared prematurely or incorrect information was shared. But I will tell you that we are very, very sensitive to the role of victims, to the role of survivors, and that you will know as soon as it's possible to share.
Well, my question was, I had information to offer, I got 3 phone calls, and no phone call back. I had information, phone numbers, names, that I called my local police department, referring to the DEA, and I've never got any response back.
I will tell you that.
I'll be happy to.
I'll turn that over.
I'll be happy to address that. And I don't know if we call it the DEA, but I'll be happy to talk to you after we're done here to make sure I get the information from you. We're willing to work with anybody during the current crisis. It's even more important that we deal with everybody from all walks of life that have any information on people that are dealing it, distributed it, and giving it to people that are dying. So you might have a missing piece that could help put us over the top on something. So please, let's make sure we talk about it.
If I could just add one thing to that. If you have information, and you call the police department, and you get the wrong person in that police department, who, for whatever reason, fails to relay that information, or maybe relays it, but you don't get any feedback, call someone else. Call me. Even if it's out of my jurisdiction, I will call Colonel Clements, I'll call Colonel
It's
Bernard.
clear to just take one.
The reality is that our cases are not that good without cooperation of the public. Your information helps corroborate things that we might be working on that can shorten the time frame of an investigation. But Jerry Coyne's absolutely right. We're not going to compromise an investigation by releasing details. At the same time, it's nice to have a name and a phone number. I completely understand now. I thought you were given it and were waiting for feedback. All right. Call somebody. Until you get somebody that confirms that they received your information, do not stop calling.
So we have, here's a pretty controversial question, and I'll allow volunteers for this one. Peter Friedman asked if we are at a stage with this, whether or not we are ready for safe injection rooms in Rhode Island.
So you want that one?
Ask it again.
The question was, clearly, right now, I think a lot of folks are not ready for that. But what would it take? How many people have to die? What would it take for us to get you ready for it? Because it has been shown to work in other towns and cities.
Other towns and cities in other countries. Neil Cookery talked about my uniqueness. I'm Josh Miller. I'm a state senator and chair of the health committee, and I've been working with a lot of these people. Some of them are tremendously effective at what they do, and I try to be a little bit effective at what I do. And I don't look forward to talking on a microphone, especially about this subject. I mean, we need to know the character too, that I'm not a politician who covets the microphone. But I do have some efforts that I want people to be aware of. As far as your question, there's political reality. And one of the reasons I've been working with these people very intensely in the last couple of weeks is because we have an opportunity, because of people that have died in Rhode Island, people that have died in New York City, people that are movie stars, people that are nobodies that have died. And people understand this more than they did a few weeks ago. And that's a good thing and a bad thing, but it's a thing for people who want to make change to exploit because it's been an issue that they care about. And we have to go in steps that are realistic. That step is far and away. There are other steps that I've been working on that probably most people are aware of, and some people disagree with me, but that have to do with decriminalizing certain drugs. And I think that will happen at a certain point, and that's because I care deeply about saving lives, not because I care about bringing us back to the 60s or anything like that. It's because I care about people's lives. When we have, as A.T. Wall said, when we have 70% of the population in a prison who would be better off with treatment than incarceration, we have to do something different. Okay? And there are... So, I think there are things that we have to do effectively that could pass first. And the attention gives us a chance to save lives. I come at this from a lot of different approaches. I could do what some people did in this room and talk about loved ones. I couldn't make it through what I have to say about legislation and about what I think would be effective if I was to use that story. So I choose not to, but I could if I wish to. So some of the things that I think would be effective, and that some of the things I'm being involved in legislatively and otherwise are, I talked to Dr. Fine, and we talk about the urgency of an issue, and he puts it in, and I love putting it in the same context of, a few years ago it was a turboprop crashing, and everybody who was in that plane dying at TF Green Airport. Last year it was a large-scale jet airplane. This year we're looking at a jumbo jet. Now what kind of community involvement would we get in changing something that must be really, really wrong at TF Green Airport if that happened in 3 years in a row? We would have a lot of political activism behind it. We hope that we have it on this issue now because of the urgency of the issue. A couple of things non-legislatively that I think would be effective: the Weber Project. How many of you knew about the Weber Project before today? A few of you did. Most of you know about the anchor recovery system. The anchor recovery. If there were 100 more Weber projects working directly with people who are the most vulnerable, there would be a difference in our community about how many people died. If there were 10 more anchor recovery centers, there would be a difference. So now I come down to the really, really boring part, is the legislation that we've been working on behind the scenes that we feel is urgent and can make a difference. And me and Director Stenning have actually, while we've been sitting here, talking about collaborating on improving this stuff. So one is mandating insurance coverage for a medication-assisted treatment, methadone, Suboxone, Vivitrol. Also, as part of that, if somebody is admitted to a doctor's office, a clinic, or an ER, before they're allowed to leave the office, the patient has to at least listen to real-time availability of in- and outpatient treatment opportunities that they can go to before they get released and have a discussion before they're to be released. There will be an expense, and some people will only care about the expense. Blue Cross Blue Shield, United Healthcare will care about how much people's insurance policies will go up based on this. If the community cares about those airplanes crashing on a regular basis, they might be willing to bear the expense. So we need people to understand that and do something about it. The other piece of legislation is that we now have Narcan-treated opioids that are available by prescription, so they're less likely to be addictive. And we want to have access and parity of access to Narcan-treated opioids. That's the other piece of legislation. So those are the two pieces of legislation. The only other thing I want to mention is, hold on one second. The only other thing I want to mention is, one thing we haven't talked about is the prescribing of Oxy and who it's prescribed to. Me and Craig were talking about the level of prescribing of oxycodone and who it's prescribed to. And more often, it's prescribed to people that are on the listening panel than it is to people out in the audience because of knee surgery or hip surgery or dental surgery. And if you give it to 20,000 more people in the community than you would have given it to 10 years ago, as an editorial in the paper talked about today, a few of those people are going to become addicts and go after heroin. And that's why, if you talk to the medical examiner, you'll understand that it's not who you think it is. It's a much wider group of people. There are several prescribed opioids that are now Narcan treated to be less addictive. And so we want parity and access to those opioids. Thank you.
I think we have time for one more answer, and it sort of sums it up. Maybe the answer is this form here, but Sarah Bowman asked, how do we coordinate the existing systems and agencies? I hope that's the question this time. That's what I heard. How do we coordinate the existing systems and agencies to sort of make this all work?
Craig's going to do that.
Well, I think tonight is the example of it. Past month, Dr. Fine, my own department, we've reached out to A.T. Wall. We've all been wrestling with this same issue and looking at various ways that we can approach it. General O'Donnell joined us last week for the press conference. My hometown is my hometown now. So I think this is happening. It used to be we were talking to ourselves. Now we have a room full of people. This never would have happened a few years ago. And part of it is the recovery community. It's brought us all under one umbrella. It's not about enforcement. It's not about treatment. It's not about prevention. It's about recovery.
Great information, and thank you for coming here, the panelists and the speakers and the listeners. And I think Jim Gillen wants me to point out that there are a lot of answers right up there, anchorrecovery.com. Thank you. Jim Gillen.
Hi, folks, just one more thing before you go. We're just going to tie it together and take about 2 minutes. All of this information will be available to you. Go to www.RICARES.org. I just want to say my name is Jim Gillen, and I'm the Vice Chair of the Board of Rhode Island CARES. I'm the Associate Director of Recovery Services for the Providence Center, and I'm from the Anchor Recovery Community Center. Most importantly, I am a person in long-term recovery from drug and alcohol addiction. And the reason I say that is that I am a success story because I was given that extra chance. I'm also in early recovery from lymphoma, treated at this very hospital. And let me tell you that addiction is no less of a disease, no less of an illness than cancer, heart disease, diabetes, and we need to treat it as such. Our message to anyone that may be still using, or if you're involved with somebody that is using, you can come out on the other side. There is hope. Recovery is possible. Overdose deaths are preventable. Hear it, and in the words of Che Guevara, you got to be ready, because you never know when it's going to happen. So be ready, okay? Thank you. Thank you to all you go.